Thank you very much, Dr. Champlin. Good morning, everybody. I want to thank the organizer, Simrit, and the whole team for bringing us to Hong Kong. For me, it was a big deal to get a visa and get a nice ticket to come here. In the next 25 minutes, I want to try to share with you some what we have on CML. I know I may not be able to cover all topics, but I will do my best. So, CML is a chronic disease. It's a disease that has changed completely throughout the years, and it is indeed a success story. Today, somebody with CML, when diagnosed, will have a normal lifespan. Means if 55 or 60 years old, he'll be 85 or 90, and most likely will not die from CML. He may die from suicide or stroke, but not from CML. Why is that? Because the tyrosine kinase inhibitors, Imatinib was the first drug approved, and now we have three options: Frontline, Imatinib, Nilotinib, and Dasatinib. These are survival curves highlighting the improvement in the survival of patients with CML. Again, today at 10 years, survival is above 90%, which is really a success in cancer. 2012, what do we have? Frontline therapy, three options: Imatinib, Nilotinib, and Dasatinib. Second line, Nilotinib and Dasatinib are approved agents. Transplant remain a major approach. And finally, we have new drugs coming down the road. One of them is Ponatinib that I will share with you at the end of my talk. So, that being said, what are the questions that we're facing in our daily practice? Frontline therapy, Imatinib, or new generation TKIs? And we know that they are expensive, and we may face some problems with that. Then, second question, great, we have great drugs. Can we cure CML? Can we get to a point where really we can stop therapy and patient will be cured? When to consider transplant, how to monitor our patients, how to make it simple, and then finally pregnancy and other questions. So Imatinib was established as standard of care based on a landmark analysis of the IRIS trial that compared Imatinib to interferon or RSE. For the first time, we showed that really the outcome has greatly improved. And not only improved, we show in this study that when you have a response induced and sustained for a couple of years, the outcome is highly predictable. We know in cancer that cancer cells are smart and they may develop resistance to chemotherapy. For example, ovarian cancer, you treat somebody with chemotherapy, they do respond, they lose the response. In CML, when you have somebody responding optimally early on, the outcome is highly predictable and the rate of transformation is really drops to zero. Now that being said, despite Imatinib being a great drug, around 40% won't do well. And therefore, there was a need for new agents. And in 2005, we launched at MD Anderson the two phase 2 trials of Nilotinib and Dasatinib in upfront setting. As you can see from this table, by 12 months, almost everybody did respond and achieved the CCYR, and that did translate into improvement of survival, transformation-free survival, 100% at 3 years. These are phase 2 trials that led to the improvement of what we called event-free survival, including transformation. And that is important because in CML, chronic phase, if patient won't transform, then he won't die from his disease. So we have to avoid transformation because once somebody has transformed, the outcome is really poor. That led to randomized trial. The first one to be reported by Pepe Saglio is the NSND trial comparing Nilotinib to Imatinib. Two arms of Nilotinib, two schedules, 300 milligram twice daily or 400 milligram twice daily compared to Imatinib standard of care. Primary endpoint being improvement of the major molecular response by 12 months. Secondary endpoint, improvement of CCYR, survival, and safety. The trial was positive. Nilotinib was shown to be superior to Imatinib. The primary endpoint and secondary endpoint were met. The last update was presented by Pepe Saglio in San Diego, again showing great PFS and failure-free survival. Although survival there was no difference, but keep in mind it's chronic disease and it's really hard to show survival improvement within short period of follow-up. But nevertheless, the primary endpoint, secondary endpoint were met, and the drug was approved. Now, for skeptical physicians, and they're right, you know, when we give a drug and at 12 months we show an improvement of the responses, people may say, well, let's wait longer because the responses may catch up and this gap will close down the road. After 3 years of follow-up, the gap is persistent and the curves are unlikely to cross, confirming the superiority of Nilotinib compared to Imatinib therapy. I remind you, MMR improvement was the primary endpoint of the trial. The improvement was significant across all the boards. for patients with high SOCA score as well as those with low SOCA score disease. I remind you that SOCA score disease was defined before the era of TKIs. Hasford score and SOCA score are merely, they were defined during the chemotherapy era and interferon era, but not for patients with TKIs. And yet, nilotinib was shown to be better across all the boards. Deeper responses, what we defined 4.5 log reduction as well, or complete molecular responses were in favor of nilotinib compared to imatinib. One key slide is transformation. As I mentioned, it's a really important milestone, and if we can avoid transformation, we can improve outcome of these patients, and yet there was a significant improvement in transformation rate. Now keep in mind, these are studies, randomized multi-center study. Patients, when they are taken off, we don't have follow-up for them. So this definition of transformation may be interpreted with a little bit of skepticism. Only single institution trial where we have a longer follow-up can give us a better idea of the transformation rate. That being said, when they transform, the outcome is really bad. Median survival is only 10 months. So we need to avoid being in such a situation. Even if you go for transplant, the outcome is not the greatest when you transplant somebody in blast phase. If there is indication for transplant, you may want to consider earlier, and I'm sure Dr. Delima will elaborate on this question. Side effect profile was in favor of nilotinib compared to imatinib across the board. Main side effect observed with nilotinib were rash, pruritus, and headache. The other drug approved as well is dasatinib. I remind you that both drugs were approved in a second-line setting before, and dasatinib in a decision trial was compared to imatinib 100 mg once a day, primary endpoint being confirmed CCYR by 12 months. There's a little bit of difference between the two trials concerning the primary endpoint, and confirmed CCYR means a patient needs to get 2 samples done within a month apart. So if you have somebody responding and had a bone marrow done and refused to repeat his bone marrow, then he will be considered failure based on intent to treat analysis. Secondary endpoint was major molecular response, safety, and survival as well. In summary, the study was positive as well. The primary endpoint and the secondary endpoint were met by 12 months, and the advantage was observed at 2 years. And an update will be presented at the next ASCO meeting in Chicago. Cumulatively, the CYR was improved by 12 months and by 24 months. Now, one thing about this slide is it's misleading. When you report analysis by cumulative way, somebody who responded, he will stay on a curve. Means this way of reporting results may give an advantage for the weaker arm. Nevertheless, the primary endpoint was met and the drug was approved. The MMR rate was similarly to what was reported at SND. I remind you that these tests were run in the same lab in Oregon, and again, the advantage observed by 12 months was sustained and maintained by 24 months. Deeper responses, CMR, were improved as well from 8-9% to 17%, and that is an important if one day you want to consider stopping therapy. Transformation rate on intent to treat was improved, although the p-value was not significant. Again, I remind you that when you have a randomized trial and patients are taken off study, then it's hard to follow up on this patient, and we may not capture later transformations. Side effect profile was in favor of dasatinib, except for pleural effusion observed with this treatment. About 10% mainly grade 1 and 2, and thrombocytopenia more commonly observed with dasatinib therapy compared to imatinib. So, for the frontline therapy, I think we have 2 great drugs. Better than imatinib therapy. There's some side effect with the chronic therapy observed with imatinib. Therefore, they are less frequently observed with the new generation TKIs. With nilotinib, we've seen rash, headache, pruritus, somebody who had never history of migraine coming to the clinic with a headache, think about side effect. With dasatinib, we still have thrombocytopenia and mainly pleural effusion. Should just be careful with that. Now, how these drugs compare together? Dasatinib and nilotinib induce higher responses than imatinib across the board. These are data from MD Anderson, many phase 2 trials having same inclusion criteria. At 3 months, 6 months, 12 months, and 18 months, there was significant improvement in the rate of CCYR in favor of both dasatinib and nilotinib compared to imatinib therapy. And that is true also as well regarding the molecular responses, whether it's MMR or complete molecular responses. That is important because the way to improve outcome is by inducing optimal responses early on, and these drugs can improve outcome of CML patient by inducing earlier responses by 3 months and 6 months. outcome is in favor of these drugs as well for event-free survival and transformation-free survival. And these are data from MD Anderson with a median follow-up of 4 years. So where we're standing today with the frontline therapy, we had Imatinib, a great drug, with higher responses at 12 months, 65 to 70%. Now, with the second-generation TKIs, we improved the rate of early responses, CCYR, MMR, with a better tolerance, but the price to pay is money. So we're going from $54,000 per year to almost $100,000 per year. So we need to wait longer to see if we can improve survival. If we do, then we have a great solution for this patient. If not, we have to reconsider our upfront strategies. So that being said, where is transplant left? Well, there's big indication for transplant, especially advanced stage disease. Upfront transplant should be offered. You may want to use TKIs as a bridge, but get for transplant. Chronic phase, 315I mutation. We have new agents, but we have short track record, and transplant should be offered for these patients as soon as possible. If you have somebody who failed imatinib therapy and had bad mutation, had bad response to TKIs, such as this patient that Dr. Champlin presented, who had after 18 months had only minor response, transplant, if he's young, had a good donor, should be offered eventually. Chronic phase patient, good response to imatinib, the likelihood of responding to second TKI is good, and therefore transplant will be deferred to a third line. And finally, elderly patient, transplant may not be the best options for them. Monitoring, it's a great deal. We have a lot of tests to be done, PCR, blood test, FISH, and karyotype. It's confusing. There's good correlation between doing a polymerase chain reaction and a blood test and a karyotype, and therefore we're moving toward more simplifying the test to be done for these patients. Milestone to be achieved is complete cytogenic response is mandatory, and once you hit this milestone, then the outcome is really predictable. So in our practice, we have good correlation between FISH and PCR, and therefore we don't do bone marrow unless at diagnosis. We do these two tests together to limit the false positivity and false negativity, and we would like to have concordant results. For example, you have negative FISH and your PCR is below 0.1%, the outcome is so good. If you have positive FISH and your PCR is above 1%, you lost your CCYR, and you better check for mutations and adjust therapy. And if you're in between, there's something going wrong, repeat the test before at least making any general conclusion and move forward. So ELN has established criteria for failure, optimal, and suboptimal. I think they are very cumbersome. Even for experts, it's hard to follow these rules, and I think they may not be relevant, and they may not be the way to go in the coming months, in the coming year, and I will tell you why. I think there's plenty of data showing that early responses are really important, and we have to move ahead, especially with options available in transplant, to optimize therapy early on, and therefore we should consider somebody not having an optimal response by at least not having a major response at 6 months and complete at 12 months. So 6 months and 12 months will give us really the key how to move forward, whether to switch drugs or to go for transplantation. Any loss of response is failure. Now be careful, in somebody who had CCYR, karyotype 100% Philadelphia negative, do not rush and switch therapy based on PCR fluctuations. These can happen, they are common, but as long as your patient is in CCYR, you should keep them on the same treatment. Why I'm saying that? From the imatinib experience published by Hagop and Tarjan, at 6 months, major response did predict for outcome. 12 months from Dr. Holman and others, we did publish same data as well as David Marine from Hammersmith, showing CCYR at 12 months is really important for event-free survival and overall survival. Whether you do karyotype and you show 0% Philadelphia, or you run a PCR and on international scale you show a value below 1%, the outcome is good. Now, these are mainly for imatinib therapy, and are they applicable for second-generation TKIs? The answer is yes. Unfortunately, I cannot show the data because the paper has been submitted for publication, but yet published so far. We showed again that CCYR does matter as a primary milestone, and these are based on 460 patients, where those 287 patients, those who had CCYR, whether they had MMR or not, the outcome was exactly the same. How this apply to the use of second-generation TKIs up front? We did a landmark analysis, and we showed at 3 months, patients who had a partial response, the white curve and above, they do good. Now, if you wait at 6 months, then you have split your groups into two categories, good outcome and bad outcome. Good outcome is defined by complete response. Anything less than that, the outcome is not the greatest. I'm not saying go and switch therapy, but I'm trying to say in a patient who is receiving dasatinib or nilotinib upfront and who do not achieve a CCYR by 6 months, just monitor them carefully and look for options, clinical trials, and things like that. Can we stop therapy because we want to cure this patient? And this is from France by Xavier Mahot. 100 patients who had imatinib therapy, who had CMR, and were followed. They had their imatinib stopped and they were monitored. 40% did not relapse. Therefore, we can eventually cure this patient and we can stop therapy. So trials are ongoing to convert this patient into CMR and try to stop therapy. What does predict for remission and maintain cure is patients who have low so-called score disease and had the CCYR for at least 5 years on imatinib therapy. In this setting, they were able to stop the drug. By no means you can do it at home. This is only in a setting of clinical trials. Patients should remain on TKI and definitely do not stop the treatment. This is my home message. Pregnancy. You know, patients are 35 years old. They are on imatinib. We say, do not get pregnant. Can we? Male patients, yes, it's safe. Female patients, short answer, do not get pregnant on TKIs. How to do it? Have a good response, have a CMR, deep responses, and then stop therapy, conceive, and monitor. What do we have for failure? New drugs are coming. One of them is very promising called ponatinib, and another one, BTG2036. So ponatinib was presented by Jorge Cortez from MD Anderson at the last ASH meeting, the PACE trial, in 450 patients who failed 2 TKIs, and some of them had 359 were given ponatinib. In the chronic phase, we've seen great rate of responses, 40% CCYR with a median follow-up of 6 months. That is really a breakthrough. So the phase 2 trial is over. They filed for an approval, and we're opening this trial in a frontline setting in our institution. Another drug, omacitaxine, it's an old drug. Unfortunately, it didn't make it. The drug has shown activity in patients who failed TKIs and had A59, CCYR 10% in the chronic phase, major response 20%. The company has filed for an approval that was denied, and they're trying to get an approval post 2 TKIs failure. Finally, where we're going from here to eradicate the disease and to cure these patients. How? Combination therapy, sequential therapy, using older agents. Dr. Khalija will discuss Pegasus in myeloproliferative disorders, but such a combination may make sense into converting patient into CMR and be able to stop therapy. Decitabine, another option, omacitaxine, and the sexy agents or the new agents, mainly HIT-Shock inhibitors, JAK2 inhibitors, among others. So finally, frontline therapy, we have great options. Imatinib and definitely dasatinib and nilotinib are better options. How to go use these drugs? Maybe induction and consolidation like we do in AML. Hit hard early on, induce an optimal response, and then maintain at a different schedule. Early responses do matter. Having early CCYR is really important, and that will impact outcome of the patient. No need to change therapy if somebody is responding to imatinib. If they have a good response, CCYR, keep them on imatinib. However, if they do not hit early milestone, you may want to consider switching therapy. When to run mutation analysis? Only in a setting of failure, not in suboptimal responders, not based on a PCR changes. Stopping therapy, no, don't do it at home. And ponatinib is a new drug to come. Thank you very much, and I'll be happy to take any question. Thank you.
So we're going to have a discussion session at the end, but maybe I'll ask just one question. So the economics is sensitive around the world in terms of caring for these patients, and for both countries and people who are paying out of pocket or have limited resources. When imatinib goes off patent, do you have any thoughts on a cost-effective strategy for using these agents?
Correct. Great question. If imatinib goes off patent in 2015-16, it may cost $1,000 per year compared to a new drug cost $100,000. It makes no sense to go for new agents unless we can come up with a predictive of outcome, like having genomic profile or some knowing upfront who should benefit from imatinib and who won't benefit. And that will be the major question for us, to be able to select to go for treatment à la carte and selecting the best treatment up front. One. Second, if imatinib is cheaper, then one way to go, we know that early milestones are really important. One strategy will be to start on imatinib 3 months, 6 months. If you have a great response, stay the course. If not, go for the other agents. But that should be investigated in a clinical trials in the coming years.
Okay. Sure.
Time for one question?
Sure.
So you didn't mention high-dose imatinib, and I know it went out of fashion with the advent of dasatinib and so on. So would you comment a little bit on that?
Okay, great. So, in a phase 1 study done, there was no MPD reach with imatinib, and there was a dose-response relationship, and that served the rationale to go for 800 milligram a day. At MD Anderson, in our hands, 800 was as good as dasatinib and nilotinib. Now, in a community, when they ran the randomized trial in a community, high-dose imatinib did induce a lot of myelosuppression, and therefore patients were taken off the trial, and therefore the top trial did not meet the primary endpoint improvement of MMR, and therefore the drug was dropped. So if you can manage myelosuppression, high-dose imatinib is a good option. Now, the new drugs induce faster responses than high-dose imatinib and have less myelosuppression, and therefore the advantage seen is not persistent.
I'm sure Dr. Jabbour is going to take up many more questions toward the end of the session. Please join us here on this stage.